Hello and welcome to Rigshospitalet Copenhagen University Hospital. I'm Ben Wilkins, Structural Interventionist Fellow, and I'm here with Dr. Ole de Backer, Consultant Cardiologist. Today we have a session for you on patient-tailored TAVR, and to illustrate some of the approaches involved, we're going to run through some case examples. So let's get started with case number 1. Alright, so for case 1 we have a 74-year-old male with a background of atrial fibrillation, ischemic heart disease and prior PCI. He has symptomatic severe aortic stenosis and has been referred by the heart team for TAVR. His anatomy shows a type 1 left-right bicuspid aortic stenosis. He has a perimeter which measures around 92 millimeters with an area of 650 millimeters squared. Minimum and maximum diameters are around 25 and nearly 34 millimeters respectively. Sinus of Valsalva is very large with a diameters of between 40 and 45 millimeters. And the sinotubular junction measures around 36 millimeters. We have an angle of implantation of 75 degrees from the horizontal, and we notice the severe peripheral calcification with this valve also. There's no concerns with vascular access for this patient with good diameters and a non-tortuous iliofemoral system. So Ole, what are your considerations when selecting a valve for this patient?
Yeah, so first of all I would look at the annulus size. So as you said, it's a large annulus size, perimeter above 85. So just because of this fact, you already some valves are disqualified, and it narrows your choice to basically two. Yes. Either the SAPIEN 29 millimeter valve or the Evolut R 34 millimeter valve. Another aspect which you mentioned is that it's a bicuspid valve. Which may also be some particularity in and have consequences for the valve choice. Of course, I think both SAPIEN and Evolut are good choices for bicuspid. Yes. But another aspect which is really important, I think, is the horizontality here, which is rather extreme with an angle of 75 degrees. So here, in a way, I would favor a steerable device, and as you know, SAPIEN 3 has a steerable modality on the delivery catheter. So that's why I think in this case I would favor slightly the choice for a SAPIEN 29 millimeter valve.
And so here, after selecting a balloon expandable heart valve, is there any additional considerations in terms of its placement and the exact size of the valve?
Well, we have the tradition in our center here to place valves in bicuspid anatomy rather high. As typically you get real anchoring and sealing in these calcified leaflets, not so much always in the annulus, but in the leaflets. And as you can appreciate, these calcifications also typically go very high up. So the bulk of the calcification is typically around 8 to 10 or even up to 12 millimeter. So that's why I think it's justified to aim for a high implantation. Sizing wise, I think it's really a large annulus size, so we cannot go around using a SAPIEN 29 millimeter. Another interesting measurement you can make is the intercommissural distance. That's 4 millimeter height from the annulus. Also, this confirms again that it's a large anatomy with an intercommissural distance of around even 32 millimeter. But considering it's a bicuspid valve, I would still do an implantation at a nominal balloon size or pressure. And not add extra cc's in order to avoid risk for annulus rupture. And he has a bicuspid anatomy, so if possible, I would definitely consider using a cerebral embolic protection system. As I show you here on this screen, I think it's not too tortuous and there's no bovine arch, so I think it should definitely be possible to place rather easily in a cerebral embolic protection, as I would use a Sentinel device here.
Excellent. And so now we'll get on and show you exactly what we did for this case. So here we have preparation for implantation, and this is pre-dilatation with a non-compliant balloon, which we typically do for our bicuspid patients. Here we have positioning of our valve just immediately prior to deployment. Any comments to make on the height of positioning here, Ole?
Yeah, so the typical implantation is, as you know, where we have the marker just above the annulus. That's classical implantation. As I said before, I would aim for a tiny bit higher implantation in this bicuspid anatomy. So 1 to 2 millimeter above the annulus is correct, and then I verify and make sure that the top of the stent frame is for sure a few millimeters above the top of the calcified leaflet tips, and that's also important to double check in order to avoid an embolization of the valve to the ventricle.
Yes. Here we have valve implantation as well. This is at nominal volume, and you'll see from our next angio run that this is a nice high positioning of this valve at a height of really 0 and 0 on the left and non-coronary cusps, with no significant paravalvular leak.
Yeah, very nice.
So for our second case, we have a 76-year-old male with a background of type 2 diabetes, previous bypass grafts that are functioning and include a Lima to LAD, a Rima graft and vein graft to the circumflex and right coronary respectively. He also has symptomatic severe aortic stenosis and has been referred by our heart team for TAVR. His CT analysis shows a perimeter of 78.5 millimeters with an area of 475. Minimum and maximum diameters at the annulus are 22 and 28 millimeters respectively. Sinus of Valsalva measures 30 by 26 millimeters, and the sinotubular junction is heavily calcified, measuring 21 by 23 millimeters. Our angle of implantation is a fairly standard degree here at 46 degrees, and we notice that there is a moderate level of asymmetrical calcification also. So at this early stage reviewing the case, Ole, do you have any considerations about your valve preference?
Well, for the range of the annulus size, I would say it's within the range of every valve. Of course, as you showed nicely, the ST junction here is rather narrow and heavily calcified. So knowing that the annulus also falls within almost in the middle of the range for, or it would lead us, if we would use a balloon expandable, to a 26 sapien valve. I think this is not good combinable with a very narrow calcified ST junction of around 21, 22 millimeters there. So that I think I would exclude. I would prefer to go to a more soft self-expandable system here, but let's see what the access also shows.
Absolutely. And here we have our imaging access here. We notice that our patient has a relatively straight iliofemoral system. However, there is very heavy calcification and relatively small luminal diameters, being generally smaller on the right than on the left here. Some areas of calcification also very severe and nearly circumferential. So at this point, Ole, has this changed your approach to the case, changed your approach to the vascular access?
Sure. I mean, first of all, the consideration you have to make if you want to, or if it's possible to do this case transfemoral, or if you want to look for alternative access. But let's say you want to see the possibility, if it's possible to do it transfemoral, then for sure I would taper it also down the valve choice to the systems what I perceive as the lowest insertion profiles, and then I think typically on Evolute and Portico systems. Okay. So going through, I think indeed the common iliac on both sides is pretty calcified, almost 3/4 to in some cases nearly circumferential. On the right hand side, well, 4.1, 3.4, it's more soft plaque, but still, lumen is very small. It looks like on the left hand side it's pretty calcified common iliac, but we didn't measure any smaller lumens than 4 millimeters, so that would give me tend to bring me more to the left side to do the case. And of course, in combination with either a Portico or an Evolute, you could do it either with the inline sheet, which is now also a possibility for the Portico with the FlexNow system.
Yes.
I think that would be probably the best, so you can avoid extra diameter for the insertion sheet. And as it is very calcified up here in the common iliac, you could even consider the use of shockwave or pre-dilatation balloon.
Okay. Any concerns about vascular closure in a patient with this type of anatomy?
Okay, so yeah, vascular closure, that's then still another thing, of course. Then we have to look to the puncture site here, and then, well, you see that even this puncture site, it is not calcium free, for sure not. So of course, Yeah, it could be a concern that your proglides might fail or break. We have, of course, also another closure device, the Manta system, available, which is a collagen-based system. I would definitely do this case always with the use of a safety wire in place. Yep. And then I think I would go for try to close with a Manta, and you can also always combine it with a balloon from intravascularly in combination with your Manta, for example, and I think could bring you to a good closure.
And so that's essentially what was done for this case, and we'll run you through the angiographic images now, although our closure strategy was slightly different using the ProGlide system. Okay. And here we have our procedure. In the beginning, we've dilated the iliofemoral, particularly the proximal iliac left-hand vessel with a shockwave balloon. This is a 7 by 60 millimeter balloon, and we've done 4 or 5 inflations inside this vessel. Following that, we've used a non-compliant ZMed 7 millimeter balloon, which has allowed relatively straightforward passage of our portico system, which is delivered, as you see here, at a nice height, and that gave us a very nice result with no significant paravalvular leak after deployment. At the end of the case, vascular closure was difficult as predicted, and the ProGlides that had been deployed very obviously failed because of the calcification that was there. But fortunately, because of the pre-existing 021 safety wire, which you see on the screen here, which is also delivered through a contralateral 8 French arrow sheath, we could very rapidly deploy a Viabahn 8 millimeter stent in this vessel for a very safe and effective vascular closure.
So it was good to have the safety wire in place here.
It turned out to be very useful.
Okay, good.
So now, Ole, we have case number 3. This is an 83-year-old man who's presented with an ejection fraction 25%, permanent atrial fibrillation, and a very rapid decline in his symptoms over several weeks. He's been declined for surgery, and on the basis of severe symptomatic aortic stenosis, been referred by our heart team for TAVR. His CT measurements are as follows. He has a perimeter of 97.9 millimeters, area of 743 millimeters. He has minimum annular dimensions of 27.5 millimeters and maximum 35 millimeters. Sinus of Valsalva measurements are 40 by 37 millimeters, and the STJ measures around 33 millimeters. He has a standard implantation angle, and as you'll notice from this hockey puck view here, very symmetrical, severe calcification, particularly at the leaflet tips. He has normal coronary heights and very good peripheral vascular access for TAVR. So for this case, Ole, seeing the anatomy here, what would your approach be to this case?
Yeah, so I think what's striking, of course, in this case is the very large annulus size. Of course, that's first should bring up a discussion in your group. I think whether you accept this case, yes or no for TAVR, of course. But okay, the man is 83, has an ejection fraction 20-25%. So. Yes. The surgeons were absolutely reluctant to operate on him. So, okay, then you still want to offer this man and see if it's possible to treat him. Well, as we know, the perimeter max range for an evolute, because then it trims it immediately down to 2 valves, the Sapien 29 or the Evolute 34 for the large anatomies. Yeah. Cutoff typically for the Evolute 34 I think is 94.2 millimeters, and for the Sapien 29 it's around 680 millimeters square. So clearly it's out of range for both, but still we could see if we could consider it for one of the two. On one hand, what would advocate for use of a Sapien 29 in such a case would be that if you would have an, let me say first, anchoring, I'm not concerned about this if you look to the amount of calcification, so it will definitely anchor. Of course, then a concern could be a paravalvular leak. And if you would implant the Sapien 29 with even additional 3 to 4 cc into the balloon, which you would have to if you would choose for a Sapien 29, a good thing with that is that you have a low stent frame, so it would be easier to do a PVL plugging with a vascular plug afterwards, because you have this low stent frame. It might be more challenging when you have a tall stent frame like Evolute. On the other hand, You also see that this annulus is pretty elliptical with a max diameter of 35 millimeters.
Yeah.
So I'm almost sure that even considering the amount of calcification with 29 sapien, 29 millimeter sapien 3 valve, even with 3-4 cc additional volume into the balloon, you might have a significant risk of PVL. And I think for such a case, I would probably favor then an Evolut 34. Hoping that you have immediately a good result after your implantation. You would not need vascular plugging.
And that is the choice that was made, and we'll go through his procedure images now. And here we have our implantation procedure imaging. Pre-dilatation is being performed here with a 26 millimeter non-compliant balloon. Following that, we have images of our valve deployment here. This is prior to release. We have a nice height here, about 4 millimeters on the non-coronary cusp and 3 millimeters on the left coronary cusp. Mm-hmm. Importantly, this valve is being deployed under rapid pacing of about 130 beats per minute. And prior to final release, we've actually waited for about a full minute to get the most out of the self-expandable nitinol frame that is used with the Medtronic valve. This here is post-dilatation of the valve. We performed this prior to measuring hemodynamics, and this is using our original 26 millimeter pre-dilatation balloon as well.
Yeah. Yeah, so one comment I can make here, so as you said, 26 millimeter balloon, we're working with an Evolut 34 millimeters. Still, I mean, you have to know that the waist of this valve is only 24 millimeters. So an actual real recommendation of Medtronic from the company is also not to go over this 24 millimeter for post-dilatation. Because if you do so, you may take the risk of tearing one of these leaflets, and cases are described like this. You could potentially take a bigger balloon, like we did, a 26 millimeter balloon, but then actually the recommendation should be to keep the balloon low, so that you only come to post-dilate this region around the annulus, and you do not take that risk of touching or tearing these leaflets. Mm-hmm. I would say even we could have had the balloon a tiny bit lower here in this case, but how did it go further with this? So we can look at the last case here, last shot.
Yeah, so the final release shows a very acceptable TAVR result here. There is mild PVL, but very good hemodynamics were seen. Mm-hmm. And importantly, following discharge at a 30-day follow-up scan, this gentleman was seen to have traced to mild PVL only, and he made a very good clinical improvement as well.
Yeah, so it seemed a good choice in this for this patient.
So case number 4 for you, we have an 86-year-old female who has got a background history of very significant frailty, severe obstructive lung disease, and ejection fraction 25%. She has symptomatic severe aortic stenosis and again has been referred by our heart team for her TAVR. Her anatomy here shows heavy calcification of a trileaflet aortic valve. It's asymmetrical calcification, which does extend for a short distance into the LVOT as well. Perimeter is 78.3 millimeters, area 484, and maximum diameters of 23 and 26 millimeters respectively. She has sinus of Valsalva measuring 29 by 32 millimeters, and an STJ measuring 27 by 29 millimeters. Ole, after seeing this patient's anatomy and the clinical background, mm-hmm. any first thoughts on how to tailor-make a TAVR result for her?
Mm-hmm. Well, of course, the major concern with this case showing me this is, of course, PVL. So how to minimize the risk of PVL in this specific case. And then, so seeing the amount of calcification, also extending a bit into the LVOT, also mentioning that this patient has a significantly reduced ejection fraction of 25%. So in a way you want to avoid rapid or fast pacing. So I think a good option here could be a mechanically expandable valve, the Lotus valve, with the pretty good, very efficient sealing skirt around it. Could probably be one of the better choices in order to reduce this risk of PVL to an absolute minimum. Mm.
And so that's precisely what was done for this patient's procedure. We'll take you through her imaging now. And so we'll show you through the images of this patient's implantation. So first up we have pre-dilatation here with a 23 millimeter non-compliant balloon.
That was guided by the minimum diameter, or?
Absolutely,
Yeah,
it was.
Here the crossing.
This is implantation of our Lotus 27 millimeter valve. Any comments on the height here in the implantation, Ole?
Yeah, well, there's no contrast, of course, but first of all, you see a very good indentation on the valve, so that's definitely a really good anchoring. I suppose the annulus is probably here, even a bit lower than where the pigtail is. So it's a regular implant of around 4 millimeters. That's what you typically aim for. But let's see how it was then. So here it's already released, of course. I would say, yeah, you can clearly appreciate that was the major concern in this case. PVL, there's absolutely no PVL, despite the severity of calcification, also even extending into the LVOT, so that's excellent. The only thing retrospectively, of course, I would say, of course, it's an elderly lady here, 86. You could have considered implanting a tiny bit lower in order to keep definitely coronary access. I would have definitely done that or considered that in a younger patient. Of course, that's a trade-off with having a higher pacemaker risk afterwards. So either you have a higher pacemaker risk and you can do a lower implant, or you aim for that higher implantation and you try to avoid the pacemaker. Mm-hmm. But I think concerning the main aim of this case, avoiding PVL, it's an excellent result.
Yeah. So for case 5, we have an 81-year-old male who presents with a previous history of previous stroke, ischemic heart disease, prior PCI and ejection fraction 40%. He has an underlying ECG with PR 280 milliseconds, QRS 98 milliseconds. He's been referred by our heart team for TAVR on the basis of symptomatic severe aortic stenosis. His CT shows annular perimeter of 76.2 millimeters, area of 433 with a minimum and maximum diameter of 20 by 28 millimeters respectively. Sinus of Valsalva measures 35 by 33 millimeters, and the sinotubular junction measures around 30 millimeters. As you can see, he has a relatively standard degree of angulation for implant and a moderate to severe asymmetric calcification of his leaflets as well. His access, vascular access for TAVR, is very good for this case. Are there any features that you would consider in terms of tailoring the valve result for this patient, Ole?
Yeah, well, as you see, anatomy-wise, I think it fits any type of valves. I would say annulus, also access, as you say. Of course, the major concern is conduction disturbance, and the ECG showed already a significantly prolonged PR of 280 or 282. QRS is still acceptable, 98 milliseconds. So of course, knowing this, I would think I would go for a valve which has the least interference with the conduction system. And in our practice, this is typically the accurate system. Mm-hmm. It's a system which deploys from top down. You can place it very accurately, I think, and also it has one of the softer radial forces, so in order to minimize that interference or impact on the conduction system. So that would be probably my choice for this case then. So let's see what we did.
Absolutely. And any thoughts about the amount of pre-dilatation that's required if you're going to consider the accurate valve?
Yeah, so typically accurate, I always predilate. For sure, if you look to the amount here of moderate calcification, I think we should definitely predilate. You could keep it with a conservative balloon. 2 diameters, I look at the minimum diameter and the perimeter-derived mean. So a balloon between 20 and 23. So perimeter-derived mean -1, that is the maximum you could use for an accurate, I would say. So, but knowing that this patient has conduction disturbance already up front, I would probably go for maybe a conservative 20, maximum 21 balloon.
Okay. And so that is what was done for this patient, and we'll show you their procedural imaging just now. So here we have our procedural imaging for this patient for case 5. Here's positioning of an accurate medium valve. This is after pre-dilatation has been performed. This was using a 22 millimeter non-compliant balloon. Any pointers in terms of valve positioning with the accurate system in this type of anatomy, Ola?
Yeah, so maybe interesting to go very short over this because it's not commonly used in the US, for example. So you have on this valve a marker, which you typically try to place at the annulus level. That's one reference point. Another point I look at is the upper crown. This is the upper crown of the valve, of that stent frame. And I like to have that just above the calcified leaflets, the top of the calcified leaflets. And then if you place it like that, as you see, the upper part is already expanded, the stabilizing arches, and then the final deployment is actually the lower end.
And here we have our final implantation showing a very nice result, an acceptable height here of the valve with just mild anterior PVL as well.
Yeah. Yeah, exactly. Very nicely implanted here, the first intersection at the annulus level, only traced to mild PVL. I think we decided here not to post-dilate, as you know, because of that very prolonged PR up front. But can you show me now the ECG, how the ECG looked after the procedure or before discharge?
And here we have our post-procedure ECG showing PR interval 282, QRS 104 milliseconds, showing no significant change from our baseline.
So this patient was discharged without the pacer then?
That's correct.
Okay, great.
And so for our sixth case, we have an 88-year-old male with a background of surgical aortic valve bioprosthesis from 2004. That's a BioCore Epic 21mm valve. He also has permanent atrial fibrillation, ischemic heart disease with previous PCI, and moderate renal impairment. On the basis of symptomatic severe aortic stenosis from a degenerative valve, he's been referred by our heart team for TAVR. CT analysis shows that he is a true inner diameter of this valve of 16 millimeters, which is very similar to the suggested 17 millimeters from the Valve and Valve app. He has sinus of Valsalva measurements, which are generally quite small, 23 millimeters, 22 millimeters, and just more than 22 millimeters here for the right sinus here. In the sinotubular junction, it measures around 23 millimeters as well. You see there's a very favorable angle of implant, and the valve itself has essentially no calcification at all. Yeah. Looking now at our coronary heights, we see here that the left coronary arises quite low at 8.5 millimeters. Similarly, the right coronary artery comes off low, but at a slightly higher 10.5 millimeters. So knowing these anatomical features and that this is a valve and valve case, what would be your first considerations for this patient?
Well, first of all, first consideration is, of course, it's an Epic 21 with a really small true inner diameter. So, of course, the first concern is that you would have a gradient after doing TAVR. And because of that reason, I think, as generally believed, is that it's better to go for a valve choice with a supraannular leaflet position. So, for people not familiar with TAVI, maybe so they have the stent frame, but actually the leaflets of the transcatheter heart valve are positioned higher than the true annulus of the native annulus of the patient. And this can minimize the risk of having remaining gradients after the TAVI. So this would bring me then for an evolute valve in this case. Second concern or consideration you have to make in this case is, of course, the risk of coronary occlusion. I mean, you have to deal with a low coronary, rather slim sinus of Valsalva. Of course, the good thing is that's an Epic valve, which is typically a valve where the leaflets are sutured on the inside of the stent, so it's more riskful, or the risk for coronary occlusion is higher when you have those leaflets on the outside of the stent frame. So that's a good thing, but still, I think in this case it's rather critical. It's better safe than sorry. So I would take some safety measurements. Two possibilities there. I think either you can consider first of all a basilica to slice the leaflet in two, opposing the left main. Another safety measurement you can make is to put a coronary wire into the coronary and having a stent, a bailout stent ready in the coronary in case of coronary occlusion.
Yeah. Here we have the procedural angiography for our patient with a first shot here showing the setup for coronary protection. There's a 6 French EBU 3.5 guiding catheter here with a guide liner as well. Inside the coronary system we see a stent ready for withdrawal if needed as well. We've chosen to use a Sentinel cerebral protection device in this patient. Ollie, any comments on that for us?
Yeah, well, we use it for sure routine in valve-in-valve cases, so yes.
Here we have positioning of our 23mm Evolute R TAVR system. We have a nice height of implant here, somewhere around 6mm, 5 to 6mm.
Yeah, and you also still have good flow into the coronaries.
So here we have a shot of our post-dilatation here. This is using an 18mm true balloon. We've gone up to 8mm, which is the recommended pressure for valve cracking. Now here we did not see the classical give of the ring of the valve, but we were very happy with this post-implantation result.
Well, we let us lead by the gradients, to be honest. Yes, so I think to remember that before we did the post-dilatation, there was indeed a mean gradient of close to 20mm mercury, and after this extended post-dilatation, there was actually a mean gradient of less than 10mm mercury.
Yes,
so,
absolutely.
And also important that you still have good flow into the coronary, so because that was one of the risks. But as you see, there was actually no obstruction of that flow in the coronary. So it was a very good outcome. Mean gradients less than 10mm mercury, no compromise of the coronary flow. So I think a very good outcome.
For our next case, we have an 83-year-old gentleman. He has a background of type 2 diabetes, severe renal impairment, previous PCI. Again, he has symptomatic severe aortic stenosis referred by the heart team for TAVR. CT analysis shows that he has a perimeter of 72mm, area 406. He has asymmetric, severe to moderate calcification at the annulus. Sinotubular junction measures 30 to 32mm, and an STJ measuring 26mm. Considerations at this point, Ollie, in terms of any particular approach to TAVR for this gentleman?
No, I think if you look to the valve anatomy, I think it's pretty routine. I think it's suitable for any valve type, to be honest.
Okay, let's check out the access. So looking at our femoral access CT, we're going to run through some images here. You'll notice initially at our side panel here, we have generally very small diameters of this vessel, 3.5mm, 1.8mm on the right, very calcified, very narrow. On the left-hand side, unfortunately not much better, very small measurements here, and again, very, very severe calcification with diameters of 2 to 3mm. Thoughts on this access?
Yeah, I mean, we showed a case before with shockwave, but this is just impossible, of course. I mean, you couldn't consider this case for transfemoral clear.
So being too dangerous for femoral access, we need to consider an alternative. Looking now at our subclavian access CT, we can see here that generally our patient has good diameters of the left subclavian and axillary vessel, 6.1 to 8mm, and a moderate degree of tortuosity, but importantly, not too much heavy calcification here. Yeah. The transaxillary percutaneous approach is our preferred alternative access in this institution, Ollie. Yeah. Would you consider this an appropriate next step?
Sure, I mean, it looks... if you even look here through, it looks pretty free of calcium. It's not very tortuous because you have to take into account this CT has been taken when the patient has the arms up. So that's why you see this kind of bend. But in reality, the patient will have his arms, even for our transaxillary cases, just beside the body. So this will even not be a bend anymore. So sure, and it has good lumen diameter, so definitely a good case for that.
Okay, so Ollie, putting together the clinical background and the anatomical features that we've just been discussing, do you have any initial thoughts as to how you would tailor-make this patient's TAVR result?
Yeah, so let me, very brief, some technical things about this procedure, the percutaneous transaxillary approach. So first, this image is about where we actually make our insertion or our puncture for our TAVI insertion. So we have typically a safety wire from the radial artery. We make a puncture guided by a combination of both angio and also echo guidance. And the closure device we use is just like in transfemoral. We do basically the puncture with a micropuncture set, But from then on, we do everything as we would be working in the groin. So we use either ProGlides or a manta closure device, and then we bring in the same sheet as we would do for the transfemoral case. So I can go further on that. Here you see, interestingly, that the insertion sheet, we typically never bring this completely over the bend of the subclavian artery. It's enough just to introduce it into the subclavia, it can even be advanced a little bit more into the straight part. And then you see now a portico valve coming, and as you see, it takes very nice and very easily this bend of the subclavian artery. So this is also our preferred valve type when doing percutaneous transaxillary. Choosing for the portico is a good combination of a low insertion profile and also a very, very flexible delivery system. So going to the final implantation results, so a very nice high implantation without any PVL, also without any conduction impact on the conduction system. And we see here, this was done with 2 ProGlides, and we had a very nice closure at the end.
So another interesting feature about this procedure is that patients are typically able to mobilize very early. This patient was mobilized 3 hours after the procedure, completely independent with activities of daily living, and given that they had no disturbance of the conduction system, they were able to be discharged at day 1.
So thank you very much for joining the session about patient-tailored TAVR. I hope you appreciated the session discussing the relative strengths and weaknesses of different TAVR systems, and also the many considerations we make as an operator when trying to tailor this TAVR to our patients. So thank you very much for your attention.